Good morning, good afternoon to those of you who've joined us. My name is Lisa Chen from the University of California, San Francisco, and I'm moderating today in my role as immediate past president of the North American Region Union. And I'd really love to welcome you to the first of what we hope is a three-part series, bringing you the best or the highlights from our recent conference in Vancouver. And I just want to acknowledge this is something different. We don't normally have a post-conference webinar series, but we realize, or the leadership group realized, that this is an unusual time for us. And we know that many people had wanted to join us in Vancouver and could not because of the current uncertainties across public health. So truly in solidarity with all of you, we wanted to bring what we think are some of the best talks from the conference, and we hope that you guys enjoy it. So I'd love to introduce our speaker today. Go ahead and advance the slide. We are honored to have our keynote speaker from our Comstock lecture from the conference, Dr. Bob Horsburgh. He's a professor of biostats, global health, and medicine at Boston University. Bob has over 30 years of experience as a TB clinician, an epidemiologist, and a clinical trialist with a special focus on drug-resistant TB. So he has served as the co-chairman of the U.S. TB Trials Consortium and the U.S. TB Epi Studies Consortium, and was president of the Union North American Region from 2019 to 2021. And he was certainly my mentor when I joined the leadership team. He's a current member of the board of directors of the union. He's co-chair of the union's drug-resistant TB working group and chairman of the steering committee of the Resist TB, which is an international organization that advocates for a global expansion of treatment for drug-resistant TB. So I'm glad all of you could join us, and we'll hand it over to Bob because you're in for a treat. This is a really good talk. Thanks, Bob.
Welcome, everyone. Thank you for the nice introduction, Lisa. And my topic today is the riddle of TB drug resistance. And I call it that because it's been a tricky issue to understand, but it's an important one. And I'll be going through some slides to try to clarify what really is going on and what the answer to the riddle might be. I don't have any conflicts of interest to disclose. And I do want to start by saying this is the Comstock Memorial Lecture, and most of you who are TB people, I'm sure, are aware that Dr. Comstock was a giant in the field of TB. He did seminal studies in Alaska establishing drug-resistant TB. He did, establishing treatment for latent TB with isoniazid. He did important studies demonstrating that BCG would not be valuable for the United States. And he had a number of important observations about the tuberculosis epidemic. In particular, he was the first one to identify that latent tuberculosis was a major source of TB disease in the United States. But in addition to that, he also was the founder and director of the Training Center for Public Health Research and Prevention, which was a community-based research unit that studied cancer, heart disease, and eye disease. It's now named after him, called the Comstock Center. And he was an accomplished bassoonist and a member of the local orchestra. So really a very talented and well-rounded man. And although I was not a student of his, I did know him personally and found him to be a delightful and supportive fellow researcher. So for this talk, I'm going to address 4 objectives. How did we end up in the mess we're in? What do we know now that we didn't appreciate then? What are our options going forward? And then lastly, what might be the answer to this riddle? So the story begins back in 1948 with the very first uh, clinical trial of streptomycin, which demonstrated that streptomycin was an effective treatment for MDR-TB. This trial showed that streptomycin treated patients did much better. There were many more of them who had considerable improvement and moderate, but and there were fewer deaths. But there was a group down here at the bottom with moderate or slight deterioration and considerable deterioration, and there were a substantial number of these people. And over time, over the 6 months course of the trial, they developed a substantial amount of almost 90% of them had resistance to streptomycin. And this was recognized immediately. Only 4 months later, in December of 1948, was an editorial in the British Medical Journal that observed that streptomycin-resistant bacilli, if transmitted to another individual, would produce disease resistant from the start, and this would be a very grave danger for the future. So people were aware that this could be a problem right away. But the advent of combination therapy allowed us to circumvent that. And these are the results of two trials done in 1952 and 1953, one in the US and one in Britain, that demonstrated that when you did combine chemotherapy, in this case with either INH, streptomycin, and PAS, or just streptomycin and PAS, you were able to avoid the generation of drug resistance because the likelihood of having resistance to three agents was only 1 in 15, 1 in 10 to the 15th bacilli, and that the TB burden was likely to be less than that. And so this really was the initial set of studies that showed that combination therapy could help us avoid creating drug resistance. Now, the question about why did this happen? Mycobacteria don't have conjugation, transduction, or transformation. They only have mutation, and mutation of mycobacteria is pretty slow. And so these two studies in 52 and 54 demonstrated that when you made drug-resistant mutants in the laboratory, they didn't grow very well on synthetic media. And then Denny Mitchison, in one of his early studies, showed that when guinea pigs were exposed to INH-resistant strains, they appeared to be less virulent. So this suggested that there was some encouraging news that these bacteria didn't seem to be quite as virulent as regular TB, and therefore we might not have to worry about them quite so much. And this was summed up by Carl Stieblo, who did a seminal series of studies in the 1960s, and he showed that at the start of his study, there was a substantial amount of drug resistance, and the results, however, of his study showed that with adequate timely treatment, they could treat all the drug-resistant patients, and it ceased to be a problem. And Denny Mitchison concluded that the mutation rate, which these resistance mutations, they had a tendency to revert to sensitivity, or they didn't grow as well, and therefore they were outgrown by sensitive organisms, and that the balance between creation of resistance and reversion to sensitivity tends towards the slow elimination of resistance. So the feeling was that it wasn't something that we needed to be too concerned about. If we did a good job with treatment of susceptible disease, there wouldn't be a big problem with drug resistance. Now, this was sort of carried on by the fact that relapses were almost invariably due to sensitive bacilli, and that if you retreated with the same regimen, 93% of the patients were cured, and therefore the conclusion was from the American Review of Respiratory Diseases that there was no point in changing a regimen if initial resistance to isoniazid or streptomycin was found, and no point in even looking for it. So it's kind of an unfortunate turn, because that meant that people did stop looking for it. But on the other hand, a couple of studies happened in the 1980s that made us take another look. This is Randall Reeves' study, which he did when he was an EIS officer. And He did a household contact investigation of a patient with what they called multi-drug resistance in those days, INH, strep, and PAS resistance, and 4 of the contacts developed resistance with that same strain. And they concluded that the potential of drug-resistant strain for causing a disease in humans should not be underestimated. Subsequent study by Phil Hopewell in Peru reported in 1985, he monitored programmatic performance and found that the standard WHO recommended regimen, only 70% were cured, 14% abandoned it, and 25% of the previously treated patients had drug-resistant organisms. So these were very worrisome observations, and these observations actually were quite concerned by some people. And this is, for those of you who don't know, Mike Eisman. And Mike Eisman wrote an editorial that came out along with Phil Hopewell's study, saying that we are tailoring a time bomb by unwittingly transforming an eminently treatable infection into a life-threatening disease that's exorbitantly expensive to treat. And Mike, as was often the case, was ahead of his time, and he wasn't really this warning wasn't heeded. And we then moved into the rifampicin era. Rifampicin was first used for salvage therapy in 1966 and first studied for newly diagnosed TB in 1971. And the New England Journal observed in 1971 that this new drug, still very expensive, is just now being released for general use and was virtually as effective as INH and even more promising. It is thought that it may replace streptomycin in primary treatment before long. And that's, in fact, exactly what happened. And predictably, by 1976, this first clinical report of rifampicin resistance showed that in Massachusetts in 1971, there were no cases, but in 1972, 2 cases, 1973, 9 cases, and by 1974, 16 cases. So it was definitely a growing problem, and in fact, it would be not something that we could avoid. And let me see if I can work on that pointer. All right. Yeah, you can see here. So these are the early treatment reports from drug-resistant TB showing in 1967 that we were able to cure patients with isoniazid-resistant tuberculosis. In 1970, we were able to use rifampin now to treat the isoniazid and streptomycin resistance. But by 1993, we had a series of 171 patients who had MDR-TB in the current definition, which is resistant to both isoniazid and rifampicin. So the definition of MDR-TB evolved as we had new drugs, and the rifampicin era just generated a new definition of MDR-TB. The global impact of rifampicin was quite impressive. The 6-month based regimen, the quote so-called short course, became the standard in developed countries after 1976, and it was prioritized in the U.S. by ATS and CDC in 1978. But developing countries continued to use isoniazid and strep-based regimens because rifampin was felt to be too expensive. And in tubercle, in 1987, we have this conclusion that in developing countries, the standardized regimen, ignoring the results of pretreatment sensitivity tests, is recommended, while in technical advanced countries, resistant drugs should be changed to sensitive. So we have the emergence of a dual standard here, where unfortunately the union and the WHO really endorsed this double standard, whereby sensitivity testing would only be done in developed countries, and it wasn't done in developing countries. And in the United States, we actually stopped doing susceptibility testing in 1985 because of changes in the way funding was distributed from the federal government. And so the block grant system led to decreases in TB funding. The wake-up call came in 1992 because the fact that we stopped doing testing led to an outbreak of tuberculosis, which turned out to be MDR-TB, resistant to rifampicin and isoniazid, and it was among HIV-infected people who were extremely susceptible to TB. And the deterioration of the New York City control program had led to many people not completing treatment, and this led to unrecognized drug resistance. And this particular hospital outbreak was the result of not only patients with unrecognized MDR-TB, but poor infection control, and a large number of patients who actually came down with MDR-TB. So this really did finally get people's attention, and the WHO in their program, the TB program in 1989 had only 2 people in it. But in 1992, when this New England Journal article came out, the U.S. recommended drug susceptibility testing be performed on all initial and final isolates. A TB global emergency was declared by the World Health Organization in 1993, and they finally endorsed rifampin-based treatment for everyone, not just people in developed countries. WHO rolled out a program which they called DOTS, directly observed treatment supervised. And this was a RIF-based regimen, which WHO continued to believe if we just adequately treated people with drug-susceptible TB, we wouldn't have the drug-resistant TB epidemic would disappear. But they fortunately also initiated global TB drug resistance surveillance to find out what was out there. And in fact, I think they were a bit surprised to find that when this surveillance was reported in 1998, that in 35 countries, almost 10% of patients with no prior treatment had drug resistance, and MDR was found in 13% of previously treated patients. So this really finally got people to respond to Dr. Eisman's warning. And Paul Farmer, who you've shown here, whose picture is shown here, had demonstrated in Haiti over a number of years that it was easily possible to treat people who had drug-resistant TB, that you had to use toxic regimens, and it was more difficult, but it could be done. And the what was called the DOTS Plus program for treatment of MDR-TB was initiated. Subsequent to that, a few years later, even worse type of TB, XDR-TB, which is resistant to not only to isoniazid and rifampin, but also to fluoroquinolones, was identified in South Africa by Neil Gandhi. And this just increased the importance of trying to identify and prevent MDR-TB. So these data demonstrated that drug-resistant TB was spreading in the community just fine. And then, and so that we really needed to get out there and start treating it. And the treatment recommendations at the time, and you can see this article by Dr. Eisman, were based on expert opinion. There were no clinical trials, but it was using second-line drugs, which a 4 to 6 drug regimen, treatment for 20 to 24 months. These are the drugs you can see here, early fluoroquinolones, injectable agents, and then other agents that were had been developed in the early days of TB, but which were relatively toxic: ethionamide, cycloserine, thiacetazine, and PAS, not well tolerated by patients. And of course, the results weren't good. Only 50 to 60% of the people who were treated with these regimens were cured. The mortality was high because of the difficulty in tolerating these drugs. There were high rates of loss to follow-up, and in particular, hearing loss was a major toxicity. Many people who had these regimens developed hearing loss because of the injectable agents, and the results were very unacceptable. And you can see several articles here from the Lancet and others about the time to get injectable-free regimens and the need to try to avoid the harm from treatment of multi-drug resistant TB. So let's go back and look at a little more carefully now. This is a recent study by Helen Jenkins and Genevieve Dupuis, which used programmatic data from the Ukraine and looked at whether, in fact, treatment of drug-susceptible TB with our standard regimen really did prevent drug resistance. And what they found in a very large study, almost 30,000 people who had confirmed drug-susceptible TB at baseline, there were 4% of the people who were treated who experienced recurrence within 18 months of discontinuing treatment, and of those, almost 1% had developed rifampin-resistant TB. And even the people who were treated for the full course of therapy, some of them had drug-resistant TB, so that it wasn't true that this completely prevented it, although the numbers were small. When you consider how many millions of people are treated every year for TB, 1% of them developing drug resistance is actually a pretty substantial number. And as you can see in the lower graph, you can see here for the people that only completed 3 to 4 months of treatment in the lower graph, there was a higher rate of drug resistance, almost 2%, and then those that completed the full course, still almost 1%. So that it, in fact, although it does a pretty good job, it doesn't completely prevent drug resistance. And of course, if people don't adhere to the full 6 months of therapy, the risk is higher. And why don't they complete the full 6 months of therapy? Well, TB drugs are not very well tolerated. Even our isoniazid, rifampin, pyrazinamide, and ethambutol have a reasonable number of adverse events. In some studies, up to 75% of people receiving treatment for drug-susceptible TB complained of adverse events, not tolerating the drugs well. And the result of that is that they don't necessarily take them as directed. They don't continue to treat them. When they feel better, they stop taking them. And in fact, in a recent study, drug-resistant TB adverse events were associated with other concomitant meds, with having diabetes, with drinking alcohol, with having HIV, with older age and lower BMI. So many of our common subgroups of TB patients have more difficulty than others in taking the drugs. So I don't think we really should be blaming the patients for not taking the regimens. We probably should be trying harder to develop regimens that are easier to take. Another recent piece of information is the question of whether drug-resistant strains are really less fit. The top bar, the top set of bar graphs shows here that these are all laboratory-identified, laboratory-derived strains of drug-resistant TB, and none of them reaches up to the bar here, which would be, as if they reach to the bar that shows a 1 there, they would be just as fit as drug-susceptible strains. So the ones that were generated in the laboratory were definitely less fit, as was observed back in the 1950s. But now below here, you can see these are strains obtained from patients, and the patient-obtained strains, half of them were equally fit, in one case even more fit, than drug-susceptible strains. So that, in fact, we had kind of had a false sense of security by thinking that these strains would be less fit. Quite a few of them are not less fit, and this explains why they continued to be spread through the population, and they didn't go away even when drug-resistant TB was well treated. The fact that combination therapy doesn't completely prevent emergence of resistance probably relates to another recent observation. In the old days, in 1953, the conclusion was that the unlikelihood of developing resistance to all three agents was quite high, but this was based on the in vitro mutation rates of the bacteria to each of the three drugs in the regimen. In 2010, a group of investigators working with Jim Collins at MIT showed that when bacteria, in this case E. coli, were exposed to sublethal antibiotic pressure, the bacteria developed resistance to antibiotics, even ones that were not administered. And this was because they increased the rates of DNA mutation, and this was caused by reactive oxygen species. So that now we're becoming aware that it may be that the conclusion from 1953 was not warranted because, again, this was based on in vitro mutation rates, and that in vivo, when patients are receiving antibiotics, they may have their mutation rates may be considerably faster, and therefore they may not be protected by our triple drug regimens. It's also, we've learned a bit more about how drug resistance is acquired, and it's acquired in a sequential manner. The first event appears to be the emergence of INH resistance, and the INH cat-G resistance arises before rifampin resistance occurs in isolates that are MDR. So that in fact, it's the first step is isoniazid resistance. And this is not surprising because isoniazid kills MTB the most rapidly. Unfortunately, there's quite a bit of variability in human populations about how isoniazid is metabolized. And people who are so-called fast acetylators metabolize isoniazid quickly, and that shortens the effective time of isoniazid exposure, leading to more sublethal antibiotic exposures and therefore likely driving the emergence of resistance. And then once that the isoniazid resistance has developed, then acquired rifamycin resistance occurs, and this has in fact been associated with low isoniazid area under the curve. And there are many populations in the world, particularly in East Asia and among Native Americans, where over half of the population has the fast acetylator phenotype. And globally, 20 to 40% of people. So it's not an uncommon occurrence, and it is probably the first event that leads to the acquisition of drug resistance. There are other factors that increase the risk of drug resistance, and these are pharmacokinetic mismatch factors, because we know that when one drug is well absorbed and the others are not, then you may not get the kind of coverage that you want to prevent the emergence of drug resistance. Isoniazid, rifampin, pyrazinamide, and ethambutol are better absorbed on an empty stomach. Rifapentine, on the other hand, exposures are increased with a fatty meal. So it's going to be difficult to have a rifapentine-based regimen that plays well with the other agents, because unless you staggered when you took your medicines. Also, the drugs don't penetrate equally into caesium or cavities. We know that the mycobacteria reside in caesium and in the cavities, and some drugs like rifamycins and fluoroquinolones penetrate these well. Others are intermediate, and some, like isoniazid, PAS, kanamycin, and clofazimine, are very poor at penetration into cavities. And therefore, if a patient is on a regimen which has some drugs that penetrate well and others that don't, there may be more pharmacokinetic mismatch. And of course, we also know that mycobacteria have both replicating and non-replicating states, and some of our antibiotics, such as rifamycins and bedaquiline, work well against non-replicating organisms, but others don't. And so that if you have a regimen that is trying to rid the host of non-replicating organisms, some of the antibiotics won't be as effective as the others. We also have to say, why is MDR continuing to spread? And the belief, even as recent as 1990, was that most patients with smear-positive pulmonary tuberculosis would have objective symptoms. We now realize that less than half of people with smear-positive TB have symptoms, and that asymptomatic people account for 35 to 51% of MTB transmission. And these people were recognized way back in 1968 by Stablo. He called them the chronic excretors of tubercle bacilli because they weren't sick enough to come into medical care, and yet they were out in the community chronically spreading disease. And even in his day, the preponderance of these people were people with drug resistance. So that this is something we're going to have to approach in order to get the MDR-TB epidemic under control, because these chronic excretors of MDR-TB are often not in treatment. We only find 65% of TB at all, and the current WHO estimate is that only 25% of people with MDR-TB are getting appropriate treatment. So that means that a lot of them are out there in the community spreading drug-resistant disease. Now, we obviously have some new agents, and bedaquiline is the one that has been the most helpful. We're all aware of the BPALM regimen, which is very effective for treating MDR-TB, but we need to be aware of the fact that bedaquiline resistance is climbing fast. In South Africa, where bedaquiline has been used regularly since 2015, over 8,000 patients received it. 3.8% of them had baseline bedaquiline resistance, and it was associated with previous exposure to bedaquiline. And among people who got bedaquiline, resistance developed during treatment in 3.5% of patients. So it's not surprising that when we have a good new drug, that resistance starts to crop up. And this is the result of having a need to treat people who have drug-resistant TB. We can't withhold bedaquiline from these people, but if we give them drugs, if we give them bedaquiline regimens without enough other effective drugs to protect from the emergence of resistance, we will see the emergence of bedaquiline resistance. This is actually quite similar to what we saw in the early days of HIV, when we only had one good treatment, and that was zidovudine. And we gave zidovudine to everyone as a single drug. And pretty soon we had a lot of zidovudine resistance. And then we added didanosine, and then we got a lot of didanosine and zidovudine resistance. So adding a single drug is definitely a bad idea. And this has been long recognized. But if we only have one good new drug, we're going to end up using it and have this problem occur, like the occurrence of bedaquiline resistance. Now, there are some things we can do to prevent drug resistance. We can certainly do a good job with drug resistance testing, initial drug resistance testing, so we know what we're dealing with. And in fact, we really do need to be doing initial drug resistance testing for isoniazid, because isoniazid-resistant people with isoniazid-resistant TB are at a much higher risk of going on to be MDR-TB. And the other thing we can do is test everyone with the NAT2 testing to see if they're fast acetylators, so we can optimize dosing, because fast acetylators do clear isoniazid quickly, but by increasing the dose, we can get around that. And there's now a nice test, and this nanopore panel that's shown here is it was just recently published in the Blue Journal, but it's a test where you can immediately see if your patient is a fast acetylator. And I would advocate that this should be part of the routine workup of anyone with TB so that we can optimize their isoniazid dosing and not generate drug resistance. And certainly, we should not be using standardized MDR-TB treatment regimens because when you do this, you end up treating a lot of people who are fast acetylators with an inadequate isoniazid dose. In addition, we need to have good susceptibility testing. This survey done a couple of years ago by Resist TB shows that in many situations outside of Europe and the Americas, less than half of the patients have access to drug susceptibility testing for bedaquiline, clofazimine, linezolid, delamanid, and protalmanid, which are the basics for treating MDR-TB. So we won't be able to do a good job of making sure we have protecting drugs in the regimen if we don't know what the susceptibility is. Now, I'm hopeful we're repeating this survey now. I'm hopeful that we'll be able to demonstrate that there's better availability, but we know that there's certainly plenty of patients who do not have access to testing for susceptibility to the current drugs being used for treating MDR-TB. In addition, TB is more complicated than HIV. With its two phases of growth, we have this issue that we need to, first of all, have an induction phase where the bugs are rapidly multiplying and they don't have that much non-replicating persistence. And then a second phase when there is sequestration of the bacteria in the caseum and cavities, and there's non-replicating persisters. So we will need to have regimens that effectively treat both the rapid multipliers and the non-replicating persisters. So here's what I think we can do. We need to develop regimens of at least 3 all-new drugs. These drugs need to have similar PK, and they need to have good penetration into caseum. They need to kill non-replicating organisms, and they need to be well tolerated. And I think if we do this, we can find ourselves in a situation closer to that of HIV, where they finally got to the point of developing 3 new drugs all at once that worked well together, that were well tolerated, and that people could take for a long period of time. Let's remember, we only need our TB patients to take the drugs for 6 months. The HIV-infected patients need to take them for life, and yet they do a much better job than we do at getting people to stay on drugs. So do we have hopes of having 3+ all-new drugs? I think we do. There are many drugs in the global TB drug pipeline. I want to focus on the ones that are in phase 1, 2, and 3, because those are the ones that are in clinical trials. Phase 1, of course, just showing that they're safe in humans. Phase 2, showing that they are effective against TB, and phase 3 showing that regimens actually are effective at curing TB. But we also have many drugs here in the preclinical stage. And although the rule is that most drugs in preclinical don't make it into clinical, there are a lot of potential drugs out there. So I think there is hope that we can develop more than one new drug at a time and actually come up with a new 3-drug regimen that will be effective. We have 18 new drugs in phases 1, 2, and 3, 9 new classes, and 5 that are completely new classes, so that we have the potential for putting together a regimen that could be effective and well tolerated. Now, these are the drugs, and you can see that under the candidates are the names. Some of them have letters, and some of them have names. The ones that have names are the ones that we know are well tolerated because the companies have decided to actually give them names. But you can see some of them penetrate well into caseum, others don't. Some have long half-lives, some have short half-lives. So it's going to be a process of putting together regimens that work well together, where the drugs don't interfere with each other, and where they can be effective in combination at killing mycobacteria that are both rapidly multiplying and in the non-replicating state. But I think this is something we can manage to do. Um, in addition, we need to optimize adherence to reduce generation of drug resistance. Um, the current drugs we have are not well tolerated. Linezolid and moxifloxacin, which is in the current 4-month regimen for drug susceptible TB, these are not well tolerated, especially by older patients. We have issues with QT prolongation with bedaquiline and clofazimine. And we need to focus future trials on improved tolerability. And this is even more important, in my opinion, than treatment shortening. I understand that 6 months is a long time, but it's easier to get someone to take 6 months of well-tolerated drugs than it is to get them to take 3 or 4 months of poorly tolerated drugs, because patients they do what they think they need to do, and if the drug is making them sick, they stop taking it, and they don't always tell us that they've stopped taking it. So I think we need to be more focused on getting the regimens to be well tolerated, and the fact that we have many new drugs, which some of which will be better tolerated than others. I can't guarantee there will be 3 easily tolerated ones, but I certainly hope so. And the HIV community drug developers managed to come up with combinations which were well tolerated. So I think we can do the same. Another thing we need to do is to do a better job of getting out in the community and finding those chronic excretors, because many of them are smear positive. And these data show that even people with absolutely no symptoms, 25% of them who had TB, 25% of them were smear positive. So these are people who are spreading TB in the community. And if we don't reduce transmission, it doesn't make any difference how good a job we do at treating it. We're never going to stop it from happening, because we have to find all the people that are out there continuing to spread it. And finding and treating them sooner will be important for decreasing transmission. This will mean we have to go out into the community and find people sooner, and get them on treatment sooner, so that the time they spend exposing their friends and relatives and the other people they interact with to MDR-TB is reduced. That's going to be the real way to solve the MDR-TB problem. So in summary, I want to point out that, the conclusions that were drawn by the people early in the epidemic were correct based on the data they had. But when we get new information, we have to rethink the theories that we are applying to our programs. And we clearly must find and treat the chronic excretors. This is still the essential drug resistance prevention strategy. And rolling out one new drug at a time will always result in its becoming resistant. So we need to develop multiple drug regimens of new drugs that we can roll out. And we may now be in a place where we have the opportunity to escape this trap of rolling out one new drug at a time, which will never solve the problem. But continued new drug development will be essential. And because the profit motive doesn't work very effectively in TB drug development, we need the support of foundations and governments, which unfortunately seems to be a challenge today. But hopefully in the long run, we can get back to the point where we actually still are continuing to develop new drugs for TB, so that we can have better tolerated and effective regimens that work well to kill mycobacteria in whatever condition they were in. So I want to just sum up by coming back to Dr. Comstock, who made this observation in 1990, that the art of epidemiologic reasoning is to draw sensible conclusions from imperfect data. And this is important because we need to remember that our data are always imperfect, and they get better. And when they get better, the conclusions we draw may change. And this is what we have seen happening over the course of MDR-TB. And I would predict that it will continue to happen. New information will come forward that may make us change our conclusions. But at the moment, our conclusions are what I hope are sensible conclusions drawn from the perhaps imperfect data that I've presented to you today. So that's the end of my presentation, and I'm happy to take any questions.
That's terrific, Bob. I have to tell you, having heard it now a second time through, I'm picking up more pearls. So Bob, there are a bunch of questions in the chat, and let me just start from. I'll scroll up to the top, and so there was discussion back and forth. Particularly, we have someone online who's up in Alaska
Mhm.
and was noting your comments about fast accelerators, and let me just there was clarification, I think, from our colleagues in Sherry in Arizona about Native Americans in general being fast acetylators for TB meds. I think you were really saying, it's fast metabolizers for INH if they
Yeah,
have
just for
this.
isoniazid. Yeah.
But and she commented, if so, it's a good sign that drug resistance is low in this population, where TB programs are community led. And then our friend Jessica from Alaska jumped in to say that there is actually a lot of INH resistance in their populations up there. I don't know if you just wanted to, any other comments about particularly those folks who see a lot of our Native American communities. Would you be advocating better access to, I don't know who's doing the nanopore testing.
Yeah, the nanopore testing is new, and I don't have information about how available it will be. I do think it's something that we need to generate some demand for it, and so I hope it will be more widespread. But yeah, isoniazid resistance is not that common, but once you get it, it does increase your risk for getting rifampicin resistance. So it is important to try to prevent it, and I will say that until about 8 years ago, everyone, the wisdom was that we could treat isoniazid resistance disease the same way we treat isoniazid susceptible disease and it would work fine. But in fact, when carefully looked at, that turned out not to be true. And the recommendation by WHO now is to use different regimens for isoniazid resistance. So every person who comes in with new TB should have isoniazid susceptibility testing done. Now that's different from the NAT2 testing, but the point is that we often are treating people who have isoniazid resistance and we don't know it because it's not part of our panel. We may find out, 6 weeks later if someone did in vitro susceptibility testing. But in areas where susceptibility testing is not done, then we don't even find out ever. So we have to do the susceptibility testing. And I think in populations like Native Americans, where there's a substantial amount of this fast acetylator status, we should be doing that too. But I'm sorry, I don't have information on the clinical availability of that test.
Yeah, no, and I think that it's probably pretty easy to say the vast majority of people who are on right now are US or North American based folks. And so you all would be doing phenotypic DST. But I will admit that currently we don't have rapid molecular testing for INH the way you do overseas.
Yeah.
Um, and so it is a problem for us knowing early on whether or not we have INH resistance. That
Let me clarify
Bob,
one thing too, because this
sure.
came up in the chat. There are two things here, and it's hard, we need to separate them. One is whether the bugs are susceptible to INH. That's INH susceptibility testing. And the other is whether the person has a gene that leads to isoniazid being metabolized and chewed up very quickly, which means it doesn't stay in the blood long enough. So the testing of the person's genomics is that's the rapid test, and that one is to help us prevent isoniazid resistance from occurring by changing by giving more isoniazid. But the second one is when it's already occurred, we need to know that it's occurred. Some people get infected primarily with an isoniazid resistant isolate. We need to know that because then we wouldn't even give them isoniazid. We need to give them a fluoroquinolone. So those are two different things. One is the genetic testing of the bug, and the other is genetic testing of the host.
Perfect. there are some questions about your chronic excretors or the asymptomatic people, with a quarter of them being smear positive. And there's a question, how do we identify these people and differentiate them from LTBI?
Yeah, well, I mean, the issue is because they don't have symptoms, they don't come into medical care. So we really need to go out into the populations and do more screening. I'm a big fan of chest x-ray screening. It worked very well in many countries for many years. It got disregarded, and I think in places where there's a lot of TB, it should be brought back. We should be doing chest x-ray screening. That's how you pick up a quote asymptomatic TB. And we should be doing it. We have lots of portable x-ray machines that are very good, and I think we could be doing more of this, but you have to go out and look for it. There's no
Yeah, in high risk populations,
in high
right?
risk populations.
Yeah, and in fact, our LTBI kind of, when you get a positive test, you are going to first make sure to rule out active
But the first thing
disease.
you do is a chest
Right,
x-ray. But
right.
if you
So
don't, I'm
yeah,
concerned about the
in the
people that,
US.
yeah, don't get LTBI testing, and they're walking around in the community not knowing they need any testing at all.
Yeah. And then how about, it said, should we be worried about drug resistance in treating LTBI? We only treat with one drug and don't test
So
for
that's
sensitivities
a
in
good
LTBI.
question. A recent set of studies showed that there actually is a way we can treat drug-resistant latent tuberculosis, but in general, treatment of latent tuberculosis does not lead to drug resistance. It's only treatment of active disease that leads to drug resistance. So unless you know that someone was a contact of someone with MDR-TB, you don't need to use the fluoroquinolone regimen for treatment of that latent tuberculosis. You can use isoniazid or rifampicin alone, and they're both effective. So there's no data showing that treatment of latent TB generates drug resistance. It does not.
Right. We're not going to get acquired resistance with
No.
it. So, and there's it may be a little akin to this. I'm just reading it now. You stated that rifampin is good for actively replicating mycobacterium. So by treating LTBI with RIF only, are we doing a disservice, or is it just as good as not for non-replicating organisms? It's
Yeah,
great
no,
for not.
rifampin
Yeah,
is a
yeah,
great drug. It's one of the few that's good for
yeah.
both. That's why it's the mainstay of treatment. It treats actively replicating and non-replicatings. Unfortunately, when you have rifampin resistance, we don't have another drug that is as good as rifampin. Now, maybe some of those new ones will be, but at the moment, yeah, no, rifampin is the best, and that's one of the reasons is it gets all forms of the bacteria.
And then hey, Andrea, were ethambutol and PZA susceptibilities done in the Ukrainian sensitive TB study?
No, they were not. It was we didn't even have isoniazid resistance. We just had rifampicin resistance because it was gene expert data.
Okay. And then Wendy Tanasi, I get a lot of pushback from patients about treating LTBI, and they're concerned that they will, one, get reinfected, and two, may even be more susceptible to TB after LTBI treatment. Huh. Are there
Okay,
any
well, no,
papers you recommend?
those are both appropriate things. However, in the United States and most countries where LTBI is the main part of our TB program, the chances of being re-exposed are quite small. So that you don't need to worry about that. I would completely agree. An LTBI program in South Africa doesn't make sense to me because we first need to turn off the pump, as they say. We need to treat all the people in the community who are spreading it. Otherwise, you treat latent, you'll just get reinfected. And in theory, having a latent infection offers you some protection, but again, you don't need that protection if your community has gotten rid of the TB. So I leave latent TB treatment aside until we get active TB under control, in which case neither of the concerns that your questioner had would be important.
Yeah, in those really high incidence countries. Yeah. And then here's thank you for this very nice presentation. One question is, bedaquiline resistance increasing faster than the resistance to other core TB drugs in the past? I mean, I think your historical view, Bob, there's been a lot of appreciation for a great historical review. It's making us all stop and rethink. But so is bedaquiline resistance happening faster than it did, say, for rifampin resistance?
Not any faster, but not any slower either. I mean, it's really the same sort of a thing. I do think that it's a it's an unavoidable occurrence when you introduce a single new drug. You can't withhold it ethically, but you need to introduce three drugs at once to get around that, and that's what was done. I will notice historically, I saw a comment in the chat here just went by briefly that the term chronic excretors is pejorative, and I agree, and it's left over from the 1970s, and I didn't mean to continue using it. We call those people asymptomatic people with asymptomatic TB, and that's what we should be calling, and that's what it is. But I just wanted to point out that unfortunately, it's been a problem that's been with us a long time.
All right. And then for those of us in the US, it'd be nice to know from WHO or anyone which countries are known to have a higher prevalence of bedaquiline resistance so we can be alert when we see our non-US born patients here. And since we are moving more and more to using BPALM for RIF intolerant cases in the US, um,
Yeah, I
I
mean,
don't know of a resource.
no, but you don't really know any place where there's a fair bit of bedaquiline being used is going to generate resistance. Now, the country that started the soonest is South Africa. So that's
Yeah.
the one where we know it exists. But all countries will have it given enough time. And bedaquiline use is now widespread so that any country that has a substantial amount of MDR-TB is going to be generating bedaquiline resistance. So, I mean, it's just a matter of time. But any country that has lots of MDR-TB, I would be suspicious about bedaquiline resistance. And we should be doing the testing. People that come here from countries where there's a lot of MDR-TB, we should test. Otherwise, you're flying blind.
Well, and Janice's, yeah, I think hopefully they may have answered a little bit of your question here, Janice. It's just what do you think, Bob, about our increasing use of bedaquiline here, given our resistance testing is not all that straightforward. It's hard, it's a send out. There are labs that are doing it now. You've got to know ahead of time to do it. It takes a while to get the results. Um,
But we can't not use bedaquiline just because we don't know what we're doing. But we do need to push hard to get susceptibility testing done. My goodness, in the Philippines, I can get susceptibility testing done to bedaquiline. Why can't I get it done here? Because you need to know. And if someone is on a regimen, which when their organisms are resistant to bedaquiline, you need to change the regimen. So it's part of good clinical practice. You have to find out whether the bugs are susceptible to the drugs you're using. Otherwise, you run the risk of generating more resistance.
well, Bob, I have to say, um, it's a good cry for us to remember, I know we're feeling bad now, but we just got to get feisty again and ask for the things that we need. Your historical view back of when public health funds went down, DST testing was stopped, only to roar back and open our eyes up. I think we don't want to have history repeat itself. And so we need to
And I think
get energized.
we can do that. You never know when one of your patients knows somebody who is in a position of political power, and we want to push for better care and use all the resources we have to get the best care possible for our patients.
Well, we're at the top of the hour. Bob, again, wonderful talk. It's always a pleasure. Thanks everyone for joining. It's been great, and we'll have two more in the series, and we look forward to seeing you again. Thanks, Bob.
Bye now.